Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hi, I'm Dr. Jacob Day, a facial plastic surgeon at Mayo Clinic in Rochester, Minnesota.
And I'm Forrest Fearington. I'm a medical student at the Mayo Clinic, and we're excited to discuss our recent systematic review of various surgical treatments for facial aberrant reinnervation syndrome, also known as FARS, that we just published in Facial Plastic Surgery and Aesthetic Medicine. So, Dr. Day, I know you've centered your practice at the Mayo Clinic around the treatment of facial paralysis and its subtypes, including facial aberrant reinnervation syndrome, or FARS. But before we dive into our paper, I think it's important to define exactly what FARS is, what causes it, and how it differs from, say, complete or flaccid facial paralysis.
So, whenever you experience injury to the facial nerve, say from Bell's palsy or a tumor or surgery or facial trauma, you'll experience an initial muscle paralysis downstream of that nerve. This loss of muscle function can either recover completely with no long-term sequelae, or it can fail to recover at all, which produces a complete or flaccid facial paralysis. It can also potentially recover partially, which we call an incomplete facial paralysis, or the nerve can recover aberrantly. This leads to muscle that moves but not correctly, and we call that facial aberrant reinnervation syndrome. Facial aberrant reinnervation syndrome is a clinical syndrome characterized by aberrant nerve reinnervation of the facial musculature and produces three hallmark clinical symptoms of facial synkinesis, which is the unintentional co-contraction of facial muscles, facial muscle tightness or hypertonicity, and facial muscle spasm. So those are the different subtypes of facial paralysis. And the last is a mixed subtype, which is a patient who has both incomplete facial paralysis and a component of facial aberrant reinnervation.
So let's say we have a patient with FARS who comes to you in clinic. What treatment options would you offer them, and how does this systematic review help you counsel them?
Yeah, it's a great question. So facial aberrant reinnervation syndrome is the most common facial movement disorder that patients experience after injury to the facial nerve, or another way to say it, even though it's not really a facial paralysis, facial aberrant reinnervation syndrome is the most common subtype of patient that you'll see in a facial nerve clinic. And when you're seeing these patients, it's important to have a good initial consultation with them, reviewing the pathophysiology, their symptoms, their goals of care, and treatment options. And there's a stair-stepped approach to these treatment options. And usually it's best to start patients with conservative therapies such as facial physical therapy focused on neuromuscular retraining and facial massage and muscle stretching, along with selective chemodenervation with botulinum toxin. And this initial treatment approach is effective for patients and it's well established in the literature. But some patients who have more significant symptoms or who don't get as good of control of symptoms with Botox alone, or patients who want more lasting symptomatic improvement may seek additional treatment options. And for those patients, we'll evaluate them and discuss surgical treatment options for their facial aberrant reinnervation syndrome and facial synkinesis. Fortunately, over the past couple of decades, we've seen many different surgical techniques developed for facial aberrant reinnervation syndrome, including selective neurectomy, selective myectomy with terminal neurolysis, and in cases where there's a component of partial facial paralysis, in addition to the FARS, these techniques are sometimes combined with reinnervation procedures such as cross-facial nerve grafting, masseter to facial nerve transfer, and sometimes even functional muscle transfers such as free gracilis muscle transfer. However, no one has been able to compare the efficacy of these different surgical techniques or combination of techniques for FARS, and the choice of technique often depends on surgeon preference and lacks standardization or guidelines. So our goal with this systematic review was to summarize the different techniques that have been used to surgically treat FARS and if possible, compare their effectiveness and offer suggestions on when to apply or offer different surgical techniques. Now, Forrest, you are one of the co-authors who helped pull the data and conduct this systematic review. So why don't you summarize some of our results for the listeners?
Sure. So we ultimately found 25 studies with 731 patients that met criteria, with an average follow-up of a little over 10 months. 7 studies reported selective neurectomy alone, 6 studies reported selective myectomy alone, 1 study reported selective neurectomy combined with selective myectomy, 5 studies reported gracilis muscle transfers with selective neurectomy and or selective myectomy, and then 8 studies reported various combinations of crossfacial or masseter nerve transfers with selective neurectomy and or myectomy. And overall, each of these surgical techniques and combinations of techniques showed significant improvement at least one clinical outcome measure compared to preoperative baseline, with only 1 study showing no significant improvement. Unfortunately, we weren't able to compare different surgical techniques against each other across these studies because there was so much heterogeneity in the outcome measures reported for these studies. For example, within the 25 studies in this review, there were 31 different outcome measures reported, often without significant overlap. There were a couple metrics, notably the FACE and E-FACE scales, that were used in 7 studies each, but most of the other outcome measures were used in only 1 or 2 studies, which made direct comparison and meta-analysis impossible. Revision rates varied widely from 0 to 53%, but revision rates were only reported in 4 studies. And then in our manuscript, we created detailed tables outlining all of the techniques, the specific areas targeted, the outcomes. And after sifting through all the data, Dr. Day, what would you say are your biggest takeaways?
First, I would say that all surgical procedures in this review yielded some improvement in clinical outcomes metrics for patients with facial aberrant reinnervation syndrome. And selective neurectomy and selective myectomy were the dominant treatment options described. Second, we noticed an interesting trend in the systematic review in that the majority of nerve transfer and muscle transfer surgeries performed in conjunction with selective neurectomy and selective myectomy were primarily reported in publications prior to 2020, while the majority of more recent publications in the surgical treatment of patients with facial aberrant reinnervation syndrome describe primarily using techniques of selective neurectomy and selective myectomy alone without nerve transfers and muscle transfers. So this may represent a treatment paradigm shift in how we surgically manage these patients away from signal upgrade surgery, such as nerve and muscle transfers, and focusing primarily on signal downgrade surgeries, such as selective neurectomy and selective myectomy. And this may represent an improved understanding of the underlying pathophysiology of this disease process. Third, I think the improvement from selective neurectomy and selective myectomy seems to last long-term, meaning greater than 12 months, but several studies showed that there may be some degree of symptom recurrence over time. No study directly compared selective neurectomy and selective myectomy as far as longevity of symptomatic improvement for patients head-to-head. So we can't comment on which technique is more lasting for patients, and it may end up being that it's segmental, and certain areas of the face are better treated with selective neurectomy, while others are better treated with selective myectomy. So I think this will be an area of future research and interest to figure this out.
So getting back to that limitation we've mentioned several times about being unable to objectively compare patient outcomes or run a meta-analysis across different surgical techniques to all the different metrics that were used. Dr. Day, what do you think can be done to facilitate comparison between future studies and really drive the field of facial reanimation forward?
Yeah, it's exactly right. I think the biggest obstacle for us comparing outcomes between surgical techniques is the lack of common outcomes metrics. And so going forward, I think the field needs to settle on a set of common outcome metrics so that we can better compare our outcomes and collaborate with multi-institutional studies. And so for patient-reported outcomes metrics, we recommend at least collecting the facial clinicometric evaluation, or the FACE scale, and the Synkinesis Assessment Questionnaire, the SAQ, as the FACE was the most commonly used patient-reported outcomes metric in our review, used in 7 studies. And the SAQ is the most direct patient-reported outcome metric of synkinesis, which is the most common symptom of FARS. For clinician-graded assessments, we recommend collecting the Sunnybrook Facial Grading Scale and the E-FACE, as these were most commonly used in the studies that we reviewed. We also support the use of automated metrics like Emotrix due to its objectivity. While facial measurements such as palpebral fissure height, smile excursion, etc., are commonly used, they're not standardized across studies, and so that makes it challenging to do statistical comparisons and meta-analyses. On the same vein, many authors perform adjunctive procedures along with the selective neurectomy and selective myectomy, such as rhytidectomy or blepharoplasty. And so there are numerous confounding variables when it comes to outcomes comparison. And so I think, if we as facial reanimation surgeons can start reporting the same metrics and clearly documenting the surgical interventions that we apply to these patients, we'll be able to come up with more robust comparative studies and better understand the long-term outcomes that our patients experience after applying surgical techniques for facial aberrant reinnervation. And that'll be helpful for us to figure out what's working well, what's not, and how we drive the field forward.
All right, I think that's a great note to end on. So listeners, thank you so much for listening to this podcast. Be sure to follow Dr. Day on Instagram at Dr. Jacob Day. Before we go, we'd like to thank the Facial Plastic Surgery and Aesthetic Medicine Journal for this opportunity to discuss our research, and also give a special thanks to our co-authors, Gloria Rodriguez and Dr. Nick Randall, for their help in this project. Thank you for listening.
We'd like to thank the authors for their commentary, and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.